We'll be starting shortly, but just as a reminder, please make sure you're tuned into the right channel. We'll be conducting this webinar in both English and French. So if you're an English speaker, please make sure you're tuned into the English channel. And if you're French speaking, please make sure you are tuned into the French channel. And we'll give it another minute and then we'll get started. All right. Hello and welcome, everyone. Thank you for joining us. My name is Lydia Mureithi, and I'm the director of the Beyond Bias project at Pathfinder International, and I'm based in Washington, D.C. Welcome to our second and last Beyond Bias Endo Project Global webinar. A few weeks ago, we kicked off this two-part webinar series by sharing with you our evaluation findings, lessons learned, and the implications on adolescents and sexual reproductive health programming. Today, we take that discussion a little further by sharing the how-to guide intended to guide you on how to adopt, implement, and scale the Beyond Bias model. Next slide. So in today's presentation, we will provide you with an overview of the Beyond Bias project approach and intervention, introduce the how-to guide by highlighting its key features, link you to sections that are most useful to you, depending on the work that you do, and of course, provide you with a link for you to access and use the guide. We will also spend some time sharing our implementation experiences and lessons learned. Next slide. As you may be able to tell from this slide, we have an exciting discussion lined up for you. And just checking again that our slides are still rolling because I can't see them. There we go. Excellent. Thank you. But I was about to say, as you may be able to tell from this slide that now you can see, we have an exciting discussion lined up for you. And you'll get to hear from multiple members of the Beyond Bias team of experts. And in a nutshell, our discussion will be broken down in two parts. We will spend the first half of the webinar presenting on the model and the how-to guide. And in the next half, we'll have a moderated panel in which we hope to share our implementation experiences and respond to key questions that you've submitted. We actually did receive quite a list of questions, so thank you for submitting those. And we hope that we'll address most of them either through the presentation, the panel session, or in the guide itself. Now that said, it is my pleasure to introduce our speakers and panelists for today. I'm joined by Marta Pierzade, Senior Technical Advisor for Adolescents and Youth, Sexual and Reproductive Health and Rights at Pathfinder. I'm also joined by Mohammed Brooks, who's a Senior Monitoring, Evaluation and Learning Advisor. I'm also privileged to be joined by members of our country team, including Bruno Key, Technical Director, Pathfinder Burkina Office, Upendo Laiza, Beyond Bias Technical Coordinator in Tanzania, and Madiha Latif, Senior Program Manager, Pakistan. And lastly, I'm delighted to have Gwen Hainsworth, who's a Senior Program Officer at the Bill and the Melinda Gates Foundation, joining us as well. Welcome, panelists. Thank you for making the time. I look forward to an engaging discussion with you all. But first off, I will hand over to Marta to kick us off with some remarks on the importance of this work on programming for youth and adolescents. Over to you, Marta.
Thank you, Lydia. Next slide, please. And then you can go ahead and go to there we go. Thank you. Good morning, good afternoon, and good evening, everyone. I'm really excited to be here with you to kick off the webinar and share the Beyond Bias how-to guide with all of you. Obviously, you're attending this webinar because you recognize the role that provider bias has in young people's ability to access the contraceptive method of their choice. While the focus of this webinar is not to define provider bias or help you understand why it's a barrier for young people's access to modern contraception, I do want to remind you of a few quick statistics to set the stage. Many of you will be familiar with the type of data that's on this slide and know that young people have high unmet need and low use of contraception. As outlined on the slide, out of 32 million adolescent women in low and middle income countries who want to avoid a pregnancy, 14 million or 43% have an unmet need for modern contraception. And in our target geographies for Beyond Bias, use of modern contraception among married women ages 15 to 19 is low, 6% in Burkina Faso, 7% in Pakistan, and 8% in Tanzania. And there are studies which cite provider bias as a driver of judgmental and poor quality sexual and reproductive care. At this point, we've talked about this project and have had multiple opportunities to engage with you and share the learnings. We've had several webinars, and by now we agree and are aligned on the fact that bias, as defined by attitudes and providers and behaviors of providers, is a barrier to contraception access. And this project has aimed to produce innovative solutions to address and overcome this challenge. But today, we want to go beyond that mutual agreement and discuss what this means for you and why the project learnings are so important from a programmatic perspective. Next slide, please. Thank you. So while we all know that bias is an issue, there is a gap when it comes to addressing it. And the status quo approach of training, occasional values clarification exercises, and supervision hasn't really worked. The Beyond Bias project was introduced to disrupt that status quo. It has been really groundbreaking in helping us understand not only what drives provider bias, but has also introduced scalable solutions addressing it, ultimately improving the quality of care for contraceptive services for young people. This was a very unique investment and has increased global and country level attention to the issues of provider bias, while at the same time building the evidence base around potential solutions. So much has been learned, but we do not want these learnings to remain on the shelf and in donor reports. We want to share them so others can use them to improve the lives of young people across the globe. The project was a proof of concept, and we have already disseminated the evaluation results in a previous webinar and report. So today, we will share our thoughts on why utilizing Beyond Bias learnings is important and how to do it. And trust me, there is a lot you can put in practice based on the learnings. We have highlighted the model step by step and share the many opportunities to incorporate Beyond Bias solutions into your work in a how-to guide, which we will outline shortly. A few things I'd like to highlight before we get started. The model can be adapted and institutionalized in different contexts and within both the private and public sector. And it can be integrated into existing programs, whether it be ongoing AYSRH programs, other FP programming, system strengthening at facilities, community level efforts, or exploring ways to apply beyond bias concepts and behavior change methods to other health areas or populations where we might see bias as a problem. So we are hoping that the key takeaway for you today is that you can start addressing provider bias today. And now I will turn it over to my colleague Brahm to give you a bit more background on the model itself. Thank you so much.
Great. Thanks, Marta. I'll be spending a few minutes kind of quickly going over the different components of the Beyond Bias intervention and some of the summary findings from the external evaluation of the project. Again, as Marta mentioned, if you're interested in the in-depth overview of the intervention and some of the key findings from the evaluation results, feel free to listen to the recording of the Beyond Bias webinar from a few weeks ago, which can be found on the Pathfinder website. Next slide, please. All right, let's start with a quick refresher of the main goal of the Beyond Bias project, which was to design and test a novel and scalable solution aimed at addressing provider bias for youth-seeking FP services in 3 countries, Burkina Faso, Pakistan, and Tanzania. The project was a collaborative partnership between Pathfinder International, the prime that provided AYSRH expertise, but also the platform to implement the Beyond Bias intervention in different country contexts. YLabs, our partner who helped us develop the novel adolescent youth intervention using HCD. Camber, who helped us integrate psychographic segmentation within our intervention. And RAND, our external evaluators with expertise in behavioral economics. Together, this consortium designed, developed, tested, implemented, and evaluated the final Beyond Bias approach. And from our collective experience, we're thrilled to share implementation insights as part of our how-to guide. Next slide, please. All right, the Beyond Bias approach is based on a behavior change strategy. And at the end of the day, it's an intervention designed to change providers' behavior on how they treat adolescents coming in for FP services. There are 3 pillars of the Beyond Bias intervention, highlighted by the 3 icons there in the middle row, which correspond to the different stages of the behavior change model, or as my SBC friends call it, the trans-theoretical model. I'll talk about what the 3 pillars look like applied in the real world in the next few slides, but for now, let's stick with the theoretical framework. So starting with the summit activates providers by targeting the stages of pre-contemplation, contemplation, and determination phases by humanizing bias, improving emotional connectivity with youth, and addressing providers' fears and concerns of community backlash. For Connect, we're targeting the stages of action and relapse, where we're educating providers around the safety of FP methods for youth, addressing concerns about fertility delays, and providing agency for providers to service youth. And finally, for rewards, we're targeting the stages of relapse and maintenance by creating accountability for service quality, offering performance-based rewards, and shifting professional norms for high-quality AYSRH services. So these 3 pillars combined, Summit, Connect, and Rewards, are designed to make changes at the provider level in what we call the 6 principles framework, which is what you see there on the right-hand side of the slide. If the intervention is implemented and designed as planned, we should see providers applying sensitive communication, providing a safe and welcoming space, work with youth to seek understanding and agreement, ensure security of information, respect the client's decision to say yes to a safe method, and offer simple and comprehensive counseling. Let's now see what the Beyond Bias intervention looks like in the real world. Next slide, please. So the provider's journey starts with the first pillar, the summit. This is a story-driven event meant to activate providers' self-awareness of their own biases and build empathy towards youth. As a one-day workshop, providers go through a series of interactive exercises, testimonies, and guided self-reflections to humanize bias. And to facilitate these conversations, the Beyond Bias team developed a personal story-driven videos in each country that allowed providers to open up, self-reflect, and emotionally connect with youth and adolescents. And let's take a look at a summit video that was developed for Burkina so that folks have a better idea of what this video entails and how it could potentially kind of elicit some of the self-reflection. So we're going to go to the next slide and play this short video.
Je m'appelle Rachida Tou. Ces événements se sont déroulés quand j'étais en classe de 4e. Je n'avais que 13 ans quand je suis tombée enceinte. Mais avant d'en arriver là, je sortais avec un garçon du nom de Hervé. Et il vivait avec sa tante. Il ne pouvait pas venir chez moi à la maison parce que mes parents étaient des musulmans pratiquants. Et un jeudi soir, après son cours de handball, on s'est retrouvés au jardin et il m'a parlé d'une conversation qu'il avait eu à avoir avec ses camarades concernant les méthodes contraceptives. Il m'a dit qu'un de ses camarades avait obligé sa petite amie à adopter une méthode de contraception et que depuis lors, ces deux-là pouvaient avoir des rapports sexuels sans risque que la fille tombe enceinte. Comme il m'a convaincue, je lui ai demandé de m'accompagner aussi pour que moi aussi je puisse adopter une méthode de contraception. Le jour où on est parti au centre de santé, il avait honte, il ne voulait pas rentrer. Mais comme je tenais à ma relation, je suis rentrée. Et j'étais en face d'une dame qui avait au moins l'âge de ma mère. J'ai demandé à la dame là si elle pouvait me proposer une méthode injectable pour ne pas éveiller les soupçons chez les parents. La dame là m'a regardé longtemps. Puis elle m'a dit, ma chérie, je ne peux pas t'administrer une méthode contraceptive. Tu es trop petite. Ça m'a beaucoup frustrée. Et je suis sortie. Hervé m'attendait devant la porte. Il m'a demandé si c'était fait. Je lui ai dit que tout était ok. 7 mois plus tard, je me suis retrouvée enceinte. J'avais peur d'être rejetée par la famille, mais mon père a su garder son sang-froid. Il m'a juste demandé l'auteur de la grossesse. Et je lui ai dit que c'était un garçon qui était dans mon école et qui faisait la classe de seconde. Malgré la grossesse, je partais à l'école. Et j'ai accouché pendant l'année scolaire. Mais malgré tout ça, j'ai passé l'examen du BPC. Mais j'ai échoué au second tour. Ça m'a fait beaucoup de chagrin. À tout ça aussi, on peut ajouter le rejet. J'étais devenue la risée de tout le monde. Mes camarades me rejetaient. Je suis obligée de me débrouiller pour subvenir aux besoins de l'enfant. À chaque fois que ma maman me regardait, elle fondait en larmes. J'étais vraiment devenue la risée de tous. Et même à l'école, certains profs prenaient exemple sur moi pour faire rire aux élèves. Je regrette beaucoup.
Thanks for playing that touching video. I get worked up every time I see that. But as you can see, this is an emotional video that allows providers to reflect, own their biases, and empathize with youth clients. After our summit, providers are enrolled into the Connect groups. And if we can go to the next slide, please. Perfect, thank you. So Connect, in essence, are interactive shared learning forums where providers share experiences and problem solve with their peers to apply unbiased family planning services. So Connect forums are hosted every month, or in some cases every other week, via WhatsApp, which is what we did in Pakistan, or through in-person meetings, which was the approach to use in Burkina, or sometimes through a blended model, which is how we implemented in Tanzania. And these connect sessions are implemented with the help of trained facilitators who can answer technical questions, but also motivate participation across the various sessions. Next slide, please. And finally, the third pillar of the Beyond Bias intervention is rewards. This is a non-monetary performance-based intervention based on client feedback that looks at provider behavior. We use client exit surveys to assess facility performance, where we develop facility report cards, rank facilities based on their performance of unbiased care, and publicly share these results and celebrate best performing facilities through quarterly reward ceremonies. Next slide, please. All right, let's take a quick look at the study setting where we implemented the Beyond Bias intervention in Tanzania, Pakistan, and Burkina Faso. In Tanzania and Burkina, we worked in public facilities where there were multiple providers in one clinic. And conversely, we worked with private providers affiliated with the Green Star franchise in Pakistan, who ran their own individual clinics. Our study sites were mostly in urban and peri-urban settings. However, we did have a few semi-rural facilities, both in Burkina and in Tanzania. It's also worth noting that in Tanzania and Burkina, the Beyond Bias intervention was layered on top of platform projects that included prior AYSRH training. And across our three countries, we had over 200 health facilities in our sample. And as part of our evaluation approach, we randomly selected half of these facilities to be assigned in our treatment group, where we implemented the Beyond Bias intervention for a year, and the other half assigned as control to help us assess intervention effects. I'll talk briefly about some of the high-level results of the evaluation in our next slide. Next slide, please. All right, so the evaluation approach used a mixed methods study design. For the quantitative component, a randomized control trial study used results from multiple data sources, client exit interviews, mystery clients, provider surveys, and FP service data to help us measure overall intervention impact. And the qualitative component involved in-depth interviews with clients, providers, facility managers, and key stakeholders to contextualize some of our empirical findings. If I had to distill the key evaluation results into one pithy slide, I would essentially use this figure shown on the screen that showcases the 4 outcome domains. The first one being provider attitudes and beliefs. The second one, looking at patient-centered care. The third one, epi methods received, and the fourth one, perceptions of treatment. So in summary, when we pool our results across 3 countries and compare findings across different data sources, the intervention resulted in large improvement in provider attitudes and beliefs, shown by the 2 thumbs up icon under domain 1. We also saw positive effects for patient-centered care and perceived treatment. Wasn't as big as the effects seen under provider attitudes, which is why we only put 1 thumbs up, both in domain 2 and domain 4. And for FP methods receive, domain 3 there, we did not see any effect in this particular domain. So one reason for not seeing any effect in domain 3 is that FP use was already quite high in our study setting, which is most likely a result of layering the intervention on top of existing platform projects. So again, the very quick high-level results from the external evaluation. So for full details, I recommend folks going to the Beyond Bias Pathfinder website where they can read the full evaluation report. We've also developed an evaluation brief and a link to the evaluation webinar that was presented a few weeks ago. Next slide, please. All right, as I approach the end of this section of this presentation, I think it's also helpful to kind of share a few quotes and reflections that gives the audience a better sense of how the Beyond Bias intervention helps providers own their bias. So I'm going to start with the first quote here, which is from a provider in Burkina Faso. I refused to offer contraception to a young girl because she was too small to start having sex. And I said, you, as a little girl, you already know boys? Afterwards, she remained mute as she watched me speak. Then she went home without her method. So 3 months later, I met her one day on the steps and she looked at me with contempt, and I noticed that she was 2 months pregnant and that her parents had chased her out. This particularly discouraged me because of my behavior towards this young girl. And I'll also share one more quote from a provider in Tanzania. I'm so touched with the summit video. The truth is, we are the reason for youth not to access contraceptive methods. We are the ones causing youth to get pregnant and making them not reach their goals by denying them contraceptive methods. Next slide, please. All right, I'll end this section of my presentation with just a few provider testimonials to hear some thoughts and reflections directly from some of the providers who had firsthand experience about the Beyond Bias approach. The first one is a quote from a provider in Pakistan. Working with the Beyond Bias network has given me the confidence that I am not alone and what I am doing is not wrong. The group gives me strength to continue what I am doing with confidence and courage. And I'll also share one final quote from a provider in Tanzania. My experience is that for many years, we have not been providing contraceptive methods to youth. I've been telling youth that they should not be engaging in relationships or having sex at young age. They should wait. Later, I was trained to provide contraceptive methods to youth. I started providing services to youth, but I was still struggling to provide services to young age, as I still see them as my children. But now I will provide contraceptive methods to youth. So with that, I'll pass the presentation back to my colleague, Marta. Marta, over to you.
Thanks, Bram. And I think that this really gives you a flavor of what is happening throughout the intervention. So thanks for telling us a bit more about the model and the 3 pillars. And now I'm guessing that all the participants of this webinar are asking themselves, how do I get in on this? Well, I'm about to tell you. Next slide, please. This is why we're here, to launch the Beyond Bias How-To Guide. As promised, we are not keeping our learnings to ourselves. We know that if we are ever going to make any real progress eliminating provider bias, we have to work together. So we have developed a how-to guide to help you take the steps to adapt, implement, and scale the Beyond Bias approach in your setting. In the next few minutes, we'll introduce you to the guide, describe the different audiences and key features, and link you to the sections of the guide that will be most useful to you. Of course, we cannot go through the entire guide here today in a webinar, but it will give you a flavor of what it entails without going through it in extreme detail. So to start, the guide is divided into 2 sections, and depending on your needs, you will focus on either one or both of them. Section 1 considers, is the Beyond Bias model right for my setting? Whereas section 2 looks at, how do I implement the Beyond Bias model? And each section gives you clear step-by-step direction to help you make decisions, adapt, and implement the model if you determine it makes sense for your setting. Let's talk a little bit about that now. Next slide, please. So I know we have a diverse audience here today, and you may be wondering if this guide is for you and appropriate for your work. I assure you that it was written and designed with many different audiences in mind. And there are different sections targeted to the unique needs of specific stakeholders. For example, if you are a high-level government decision maker and recognize that provider bias is an issue hindering AYSRH services, you'll want to focus on section 1 of the how-to guide to determine if your country should adopt the Beyond Bias approach to help overcome the challenge of provider bias as it relates to adolescent and youth sexual and reproductive health. This is more about deciding whether the model is right for your setting. Next slide, please. Next slide. Did I skip one? I think I skipped one. Sorry, back to that one. Thank you. As a program implementer, let's say you work as a MOH program officer at the national or subnational level. You'll want to focus on both sections 1 and 2, to guide you in adopting or integrating Beyond Bias into your existing national program and provide support for implementation. The annexes, which are extensive, will also provide additional resources for public sector implementation. Next slide, please. Let's say you're a donor agency decision maker looking to support national partners in mitigating provider bias, and you recognize that bias hinders delivery of AYSRH services where you provide technical and/or financial support. In this case, you would likely want to know if Beyond Bias is a model that you can recommend for application in the settings you support. So again, you'd want to focus on section 1, which will help you in deciding if Beyond Bias is right for you. Next slide. And finally, if you are a member of a donor-funded implementing agency, whether it's an NGO, an INGO, a community-based organization, or even a private franchise working with reproductive health providers, you will likely need to better understand what the approach is and how to roll it out in your country or setting using donor-provided resources. So you'll want to focus on both section 1 and section 2 of the guide, while also considering the additional resources in the annexes. Reflecting on your situation and considering why you are interested in the Beyond Bias model will help you make decisions of where to start. Of course, all of this is clearly outlined in the how-to guide, with plenty of additional tips and implementation support. Now I'm going to turn it back over to Lydia to provide a bit more detail on the key features of the guide. Thanks so much.
Thank you, Marta, for that great overview of the guide intended audiences and how it can be used. So in the next few slides, I'll describe what to expect from the guide in terms of the content, how it is set up, present its key features, and let you know where you can access it. Now, in terms of content, the guide is designed to answer foundational questions, including why provider bias is a problem and what the key drivers are. It also provides the rationale for Beyond Bias approach to addressing provider bias and why you should adopt it. Furthermore, from the guide, you will also be able to assess if the Beyond Bias model is right for you or right for your setting, including weighing decisions around the adaptability and scalability of the various components of the model. Now, a key point I'd like to note here, which is also well articulated in the guide, is that even if you do determine that you're not ready to adopt the full model for whatever reason, still there are insights, tips, lessons that you can take away from the guide that will improve your youth programming today. So that is to say that there is something for everyone in this guide. Next slide, please. The guide takes you through a series of logical steps to help you navigate through the implementation process. But please note that our intention was to be descriptive rather than prescriptive for the most part. So once you understand what each step entails, then you can use your own judgment to make the necessary adjustment to fit or suit your given situation or context. That said, though, there was a question that was submitted that asked about how to balance between adaptation and fidelity to the model, which I think is a great question. The good news is that we do address this particular question fully in the guide because we clearly lay out what aspects of the model you need to adhere to and what elements you can adjust to fit your context. Next slide. So we've endeavored to make this guide easy to follow and user-friendly. But at the same time, we wanted to share with you as much or as many tips and do's and don'ts as possible so you can avoid the pitfalls that we suffered, because there were quite a few. The goal is for you to even be more successful than we are. So please take the tips at heart and learn, so you don't have to suffer the same challenges we suffered if you can avoid them. So for areas where we felt that our approach was unnecessarily burdensome, given that we were operating within the context of a randomized controlled trial, we offer alternative approaches for your consideration. So check that out too, because you're implementing in the real world. Ours was a proof of concept. So we were held to some research standards that you don't have to adhere to. You're moving on to taking this work on and scaling it. So you use monitoring and evaluation tools which will guide you, which the guide provides, but you necessarily don't have to adhere to some of the strict measures, almost petri dish situations that we were in due to the RCT. We also provide a wealth of tools, as I've mentioned, and materials that we've already developed, so you don't have to reinvent the wheel. So check those out as well and make use of them. Next slide. So here's one example of a page from the guide to illustrate some of the key features I've been talking about. As you can see here, we have a numbered and titled step, then some background information that grounds the step within the context of the program, and briefly, and a brief summary of why this step matters. Next slide. Here is yet another example where we provide a step-by-step guidance on how to plan, implement, and monitor a specific activity. We then provide a pro tip, as I've been saying, with do's and don'ts based on our field experience executing these various steps. So again, those will, I think, will come in handy as you go through the guide and figure out your own implementation and adapt the model. Next slide, please. And without further ado, I wish to have drum rolls. Here's a link to the guide, as you can see on your screen. And the link is currently being shared with you in the chat box for your convenience. To be honest, and without a doubt, this guide is truly a labor of love from the Beyond Bias team to you, our audience, and to every young girl, every young woman, everywhere. So we hope that you find it instructive and valuable to your work and to advancing the services and care, quality of care for girls and young women. For our Francophone colleagues, we've not forgotten you. The French version of the guide is in the works, and it will be available very soon, in about a week or so. So please be on the lookout for that as well. It will be also linked on the same page where the English version is, and we'll be sending materials later after the presentation, so you'll have that. And with that, I'll now hand over back to Marta to moderate the panel session. Over to you, Marta.
Thank you, Lydia, so much. It is really exciting, and as Lydia said, a labor of love. You will learn more in the next 45 minutes or so from the panel, how much commitment and effort went into this project to ensure that we were creating, lessons learned and innovations that now we are thrilled to share with all of you. So thank you again, Lydia, for walking through that with us. And now we get to the exciting part of the webinar, where we will hear from our panelists about their experience with Beyond Bias. When you registered for this webinar, you may remember you had the opportunity to submit questions to the panel. And did you ever? Thank you so much for your engagement. We actually received so many questions that we selected from and are thrilled to use them to guide our discussion today. I do see more questions coming into the chat, and don't suspect we'll have time to get to additional questions, but I assure you, as Lydia said, that many of the questions that are in the chat have been answered by the how-to guide, and others will be answered during the panel now, and there will be some follow-up after this webinar. So as a reminder, before we get into the panel, please ensure that you have selected the correct language channel. Some of our responses from the panelists will be in French today. So if you are an English speaker, please ensure that you have selected the English channel rather than the original language to hear any translation. And you can do that by clicking on the small globe on the menu bar and selecting either English or French if you have not done so already. Next slide, please. Great, thank you. We will host the panel in 2 segments. The first will focus more on our implementation and our country experiences. Then we will expand more to a global perspective and looking toward the future. So first, I would like to invite Bruno, Mediha, and Upendo to turn on their cameras for the panel discussion. Great. Okay, great. I cannot see all the cameras, but I think we're all on. Yes, we are. Okay, great. Next slide, please. Dr. Bruno, I have 2 questions for you and would like to start with you in Burkina Faso. First, the buy-in of the Beyond Bias work at the country level has been phenomenal. In Burkina Faso particularly, Pathfinder was invited by the Ministry of Health to integrate the model within the AYSRH national strategy. We'd love to hear more about that from you. Could you speak about how the team was able to achieve this level of buy-in and support from the government? And secondly, in addition to working closely with the government, we learned quite a bit about the nuances of bias itself. For example, the roots of provider bias in Burkina Faso were found to be largely situational and structural as compared to the other 2 countries. So what did implementing the Beyond Bias model in Burkina highlight that could make the project even more impactful moving forward or in a different context? Over to you, Dr. Bruno. I think you're muted, Bruno.
Yeah.
Thank
It's
you.
okay now?
Yes, we
Okay.
hear you now.
Ok. Merci, Martha. Je pense que tu poses
Thank you
ici
so
deux
much, Marta.
questions très
So,
intéressantes dans
those
le
are
contexte
very
burkinabé,
interesting
la mise en œuvre
questions
de la solution
in
Bâtir
the
l'avenir.
Burkina context.
Alors, pour la première question,
So, to
il
answer
faut
the
noter,
first question,
que nous sommes juste partis du principe du cadre
we
conceptuel de l'OMS
started with the
pour le
structural
passage
framework
à
of the
l'échelle
World Health
du cadre
Organization
conceptuel
to scale up
de la mise en œuvre des interventions.
and to implement
Alors,
the interventions.
Alors, tout qui veut dire tout simplement
What
avoir
does that
le
mean?
but à l'esprit.
So we have to keep in mind a specific guidelines. So since the inception of the project, there was the implementation of a participatory framework with all the different structures on the national level. So for example, it was the implementation of a consulting committee, which involved the Ministry of Health, local associations, youth organizations, also research institutes, but also the different municipalities association of Burkina, so and everything under the aegis of the Ministry of Health. So this committee formed a support team and helped facilitate the whole project. So we did, we took into account all the different approaches and to involve the youth and to make sure we were able to scale it up nationally at the Burkina Faso. So with regards to the institutional framework, we also worked with the central direction of the Ministry of Health, but focus on health quality, health delivery quality, and helped the implementation of a monitoring tool. So that basically sums up everything that we did so that we could bring this, this project to life. With regard to implementation, it is an intervention that focuses health workers. However, this intervention was not initially created to address all health issues. So within the Burkina Faso framework, we're experiencing other issues at the health system, which could have possibly challenged the project. So for example, a lot of mobility of health workers, but also too much work on each of those health workers, which prevent them from respecting the and providing decent health services. We also had to reinforce the capacity on the structural level, and we also had information or privacy issues. Be that as it may, we had to experience like a program challenge so that we could help those youth to have access to those contraceptions. As you saw it in the video, that young came, she showed up and she asked for contraception. That's the reality. And many of those youth judge the quality of the services that they were given, considering the type of contraception that they receive. So how do we actually contextualize our message? How do we respond the best way possible? How do we respond to their request? And based on everything that I've said, every passage to scale should require a systematic approach. And it would be very interesting to look into the choice, the method of contraception, especially with the youth. Should we always label the process regarding the decision-making process? Is it an approach that we should encourage or not? That is a question that we need to keep asking ourselves. But in the meantime, let's do our best to continue and resolve the bias on the service level, on the service provider level, and provide the best solutions possible to our youth. Over to you, Marta.
Thank you so much, Bruno. It's really incredible to hear the unique experiences from Burkina. And to those of you who have not read the evaluation report or participated in the previous webinar, please do take a look at that, and you will really understand the nuances of implementation in the different countries, and where that's what we're really trying to give you a flavor of with this panel. So thank you for sharing that experience, particularly because of the strong relationship that you have with the MOH and engagement of youth through the scale up. We've learned so much from Burkina, and we appreciate your sharing that, Dr. Bruno. Now I'd like to hear about the experiences from the other two contexts where we implemented, starting with Tanzania. I see you've already changed the slide. Thank you. So, you know, having just heard about the incredible support from the government of Burkina Faso, now I'd like to shift gears a bit and talk about implementation in Tanzania and a little bit more about providers' experience. The engagement of providers with the Beyond Bias intervention in Tanzania was very impressive, and so was the impact. Upendo, which aspects of the way you implemented do you think have contributed to your success is my first question. And then also in Tanzania, Connect was implemented as a blended model. You may remember when Brahm was going through the different pillars, he talked about how Connect could be implemented, and one was as a blended model. And in Tanzania, that's what we did. It was both digital through WhatsApp groups, but also with in-person meetings at facilities with providers. So that's quite different than the other two contexts where everything was done, you know, where things were done more in person. So, or one way or the other. So, Upendo, could you also tell us why this decision was made to take a blended approach and how this model worked? Over to you.
Thank you, Marta. Good morning, good afternoon, good evening, everyone in here. Thank you for the great question, Marta. So, well, in Tanzania, just like in Burkina Faso, as Dr. Bruno noted earlier, the Beyond Bias initiative actually achieved the great buy-in from the government, specifically from the Ministry of Health, as a novel approach to address provider bias. Also a novel approach to improve the quality of AYSRH services to adolescents and youth clients. To be specifically here, the Ministry of Health played a key role in giving what we call social permission to healthcare providers to serve adolescents and youth without the fear of community backlash. But as a regional implementing region, the regional health management team adopted on the initiative and took a front seat in the implementation by supporting and overseeing the participation of facilities during the implementation time. But most importantly in this, the end users, in our case, the healthcare providers in this case, appreciated the Beyond Bias model. They actually felt they are heard, they are valued, their struggles have been recognized, and also their efforts towards improving the quality of service in this regard, sexual reproductive health services to adolescents and youth, are appreciated and valued. In this case, also in Tanzania, the use of positive deviance actually gave us a good step towards the success of the implementation, because the positive deviants who are converted healthcare providers and great adolescents these are converted healthcare providers and actually adolescents model who are giving the services to adolescents without bias, without being judgmental, took a great lead in helping the others to also change and perform better. So all these factors gave healthcare providers the will to do better. But on top of this, in Tanzania, we actually expanded the motivation categories, whereby providers were motivated, were recognized, in this case, socially recognized by the Ministry of Health, by other players in this act, by expanding these categories, by giving them the motivation. So the motivation went from being facility-based motivations to district and individuals. So going to the second question, in Tanzania, the first, during the live prototyping, Digital Connect was tested and it did not perform well. Providers felt that this model of connecting to their peers and others actors in this journey of giving services to adolescents and youth actually consume their time and also use their internet mobile data, but it was also, they felt like it was an assumption that all of them have access and can utilize the smartphone. But to address this challenge, actually, the blended model was adopted in Tanzania. And the blended model was actually a combination of both digital and in-person connect, where Digital Connect evolved to become a forum moderated by positive deviants, where provider primarily shared their experience, their dilemmas, and they could problem solve together. Whereas also in-person connect sessions were facility-based and curriculum-driven discussions. These both two forums actually complemented each other very well, and the participation remained high throughout the implementation period. So these factors actually accelerated to great success in Tanzania. Over to you, Martha, and thank you.
Thank you, Upendo. And hopefully you're all getting a sense of how this model is adaptable and how impactful it can be for provider behavior change when we work with them and within the diverse context to ensure the model meets their needs. And we're going to hear a little bit more about that here now from our experiences in Pakistan. Next slide, please. Great, thank you. So we have, as I was saying, we've learned so much about the contextual influences, like how context influences different types of bias. And we've heard from our countries both about working with the government and providers' experience. And now I'd love to hear from you, Medea, about the unique experiences in Pakistan. Pakistan is the only country where we worked in the private sector. So it was a very unique to the other country experiences. So Medea, could you tell us a bit about those unique challenges of working with private providers and how you overcame them? And also, do you think that the Beyond Bias model can be implemented successfully in the private sector in Pakistan? And if so, what adaptations would be needed for that to happen? Over to you.
Thanks, Marta. The questions you pose are really important for consideration, but also to put into context the different ways we can implement this model. So working with private providers particularly is very different from working with public providers. So for private providers, there is a dependency on their free will to participate in the program, given that the clinics that they run are their individual enterprises, unlike their public counterparts who can be held accountable for their participation by their supervisors or their managers. So we had to be really strategic in our approach by building in value for providers in the program to motivate and encourage their participation. So first, most importantly, we worked towards helping the providers look at the youth subpopulation as a key demographic to increase their client base. And fortunately, we had learned early on from the design phase that building a business case for the program was a very effective approach. So working with our local partners, Green Star Social Marketing, we included an additional session on the summit agenda. We also included it in the Digital Connect curriculum and really worked to improving and helping our providers understand the need and the essential elements of adding youth clients with the aim of improving service delivery for young people. So we motivated them through this process and helped them understand that the youth was an essential segment and population that was untapped and could be leveraged to build their own client base. And second, we also had to ensure their participation in our in-person events, because any kind of physical participation always came at a personal income loss or a personal cost. So these events really had to be energizing, creative, and interesting and really pull them in. So for added benefits to their participation, we brought on board different mentors and role models that these providers could relate to both professionally and personally, and invited them to come and speak and share their experiences with these providers. We also thought of and then did execute adding on self-care elements on the agenda. So organizing mindfulness activities such as yoga and art therapy and laughter sessions as special elements that were personal and centered around the providers. And then finally, we also continue to adapt our reward categories. And in order to encourage digital connect participation, we expanded our award categories to include a reward for their participation on Connect, and continue on to build on that. So when we talk about Beyond Bias for the public sector, I truly believe that Beyond Bias is a model that needs to be implemented and scaled in Pakistan, particularly with the public sector, because provider bias exists in both spheres. It exists in the public and the private sector, and it's an essential area to address in order for us to improve quality of service delivery. The Pakistan public sector healthcare system is extensive and has multiple layers. So I think the model could support in creating a larger enabling environment for young people if applied across the board. Public service providers and facilities do serve a large portion of the population and are free of cost. So they're an important area of intervention, given the access that people have to these facilities. So in our conversations with technical experts and advisory committee members, it was continually stressed that public sector adaptation was essential for Pakistan, and there could be multiple ways that we could look at these adaptations. For one, the principles of care could be included as part of our performance management frameworks and client satisfaction surveys within the health systems that already exist. And we could institutionalize it as a continued learning and support model for service providers. We could also consider developing key master trainers within the systems itself as part of pre-service and in-service trainings, and even include refreshers to roll out this model regularly in a hybrid connect curriculum similar to the ones in Tanzania. And we could include particularly the pillar sessions, which are the summit and the reward events. They could be adapted as part of the technical committees that already exist and are a part of the system. And I just wanted to add here that Pathfinder Pakistan did replicate a bit of this, the Beyond Bias model under our Naya Kadam project, which was a flagship project working with public facilities in 6 districts in Sindh and Punjab on post-pregnancy family planning, with a focus on young couples, and we tested this out within that project. It did prove to be cost-effective and ensured peer recognition, encouraged healthy competition, and as per the observation of the implementers, it worked really well. So while some tweaks and adaptations can be made for public sector scale, I think it's an important intervention to address a very pertinent and pervasive issue in Pakistan. So thank you. Back to you, Marta.
Thank you, Medea. It's so interesting to hear how you engage private providers. And I know, I'm seeing a couple of chats come in here, and it is quite different than the public sector. But to think about how that, as you answered in the second question, how we may be able to adapt the model, for different sectors, it's really important. And I appreciate your thoughtfulness with your response. And thank you to all of you for sharing your country-based experiences. It's so important to understand the nuances of implementation within different contexts. And you've really given us a picture of how the Beyond Bias model can be adapted. So thank you for that. Now I'd like to shift gears a bit from the country context to a more global perspective and some lessons that we've learned that participants of the webinar can take to begin to think about how, about using the how-to guide in your own programming context. As we discussed earlier, we sourced questions during registration, and many of those came from you. So thank you. And we're going to get into some of those now. So I'd like to ask Brahm, Lydia, and Gwen to all turn your cameras on and join me now for the global panel. And we could move to the next slide, please. Great. Thank you so much. first, I would love to ask you a few questions, Brahm. Thank you again for giving us such a great overview of the model itself earlier. But now I'd like to start by looking back at some of the learnings from implementation that participants can take forward. It'd be great to hear from you a bit more about the monitoring, evaluation, and learning, or the MEL perspective. I saw a couple of questions come in the chat about that. And as projects and countries think about adapting and implementing the Beyond Bias model, what are some important considerations when it comes to monitoring the project? And also, what are some important learnings or adaptations based on project monitoring data that you could share with us? Over to you.
Great. Thanks, Marta. Good set of questions. And I always tell folks that good programming starts with good M&E. So in this case, the monitoring data is useful to ensure that the different Beyond Bias activities are being implemented as planned. So the number of summit, connect, and reward sessions, but also the level of engagement that providers have with the different components of the Beyond Bias model. So as a result, I think it's important to consider a mixed methods approach for monitoring project data associated with implementing varied versions of the Beyond Bias approach. So for the quantitative component of our monitoring approach, we're tracking the proportion of providers that participated across the different summit, connect, and reward session. And that level of engagement is important to track to see if there are particular facilities or areas that just require an additional level of support to ensure appropriate and meaningful engagement. And for the qualitative component of some of our monitoring approaches, we did a lot of facilitated discussions with both providers and implementers across the different summit, connect, and reward sessions to assess, engagement, but also to figure out what's working, and more importantly, what's not working. Document any shortcomings that we've kind of ran into, and finding ways to improve upon them. And as a result of some of our monitoring data, we did see a few important learnings and made some adaptations to better strengthen the overall Beyond Bias approach. So, for example, our monitoring data suggests that higher Connect participation often resulted in higher reward scores associated with kind of quality of care. So when we group facilities based on low versus high Connect participation, we saw that facilities with higher Connect participation on average had higher reward scores and were providing better performance to clients. So, we use this information to motivate provider participation in Connect, and by engaging facility managers, motivating providers based on some of the data that we've seen, we're able to actually increase Connect participation by over 10% from the first quarter all the way to the final quarter. So again, using the data to kind of share and motivate both providers and facility managers, I think, is an important lesson. We also learned early on that additional opportunities to win prizes and recognition was also very helpful to motivate and incentivize providers. So in our monitoring tools associated with the first reward ceremonies, we got a lot of feedback from both providers and facility managers that they wanted more opportunities to win. So as a result, we've kind of adapted subsequent reward ceremonies to increase the number of reward categories over time. So for example, in the beginning, our first reward ceremony often focused on recognizing the facilities with the highest reward scores or the best performance. But then subsequently, the second and third reward ceremonies expanded some of those reward categories to include categories such as most improved in terms of their reward score, best participation in Connect, and it allows opportunities for a lot of the participants, providers, and facilities to kind of be part of the process and increase their chances of winning. So these are some of the lessons that we've learned from the monitoring approach that we've highlighted throughout the how-to guide. So hopefully these are some useful insights to help answer this question, Marta. So back to you.
Definitely some useful insights. I love to hear how you use the data to share and motivate providers, and that you really, consider the feedback of providers in implementing and adapting the model, especially, giving rewards based on most improved. We always can improve in those ways. So thank you for that, Brahm. Next slide, please. So, Brahm shared a little bit about our excuse me, about the MEL learnings. And as we continue some of our discussion around learnings, segmentation was certainly one of the novel approaches that we tested. And a key question that we've constantly received is on the use of segmentation analysis. So while we didn't go into great detail about segmentation during this webinar, we have discussed it in previous webinars and a technical brief. But I'd love to hear from you, Lydia. What lessons did you learn from integrating segmentation analysis and Beyond Bias? And what recommendations do you have on how these lessons can be applied to future work?
Well, thank you, Marta. And it's very true. That's a question that never goes away. It's a question that has persisted for a long time. And at first, I would like to say and point out, just like Marta said, we do actually have a brief where we've documented our lessons learned from 4, not just Beyond Bias, 4 Pathfinder programs that have integrated segmentation analysis in their approach. So please do check that brief out, because again, it sounds like a shameless plug, but really it's just given on the level, the intensity of how much we get and how often we hear this question. That is, I think, a resource that might be helpful for you. But if I may try to summarize what we've learned in a few points, for now, I would say 1, not that there exists, when it comes to segmentation, there exists a real tension between scale and nuance. And that's a real issue you have to think about. So the more complex the variables you use to segment your intended audience, and the more or the smaller the segments you have, the more the nuance you will get to tailor your messaging, which is a great thing. But the other side of that whole story is that it will be the more nuance you have, the less generalizable your findings are going to be. So it's just to say, again, it's a dance you have to dance and be careful about it. So I would say, think carefully and determine from the onset, before you get started, how to best balance that tension, and then make decisions based on the goals of your program, on what fits and what works best for you. So a second point I'd like to make is in relation to the point I just made is, do your due diligence to determine what level of segmentation analysis is most useful to you. Again, segmentation, psychobehavioral segmentation is newer in global health, but the field of global health is always segmented and mostly using demographic variables. But when you have topics like Beyond Bias, those are complex behavioral issues that psychobehavioral segmentation that looks at other variables like individual attributes and behaviors, then you may need, a different level of segmentation. So what I would say is that be careful or determine from the onset what is the most useful, what level of segmentation is most useful for you. So for instance, if you're able to tailor your messaging to your audience, to your intended audience, quickly using readily available data, or using information from a quickly pulled together meeting with stakeholders, or even by conducting a simple qualitative inquiry, then you may not really need to undertake the large scale quantitative segmentation analysis that tends to be more labor intensive, more labor and cost intensive. So that's again a decision point that you need to consider on the outset or from the beginning. And lastly, I would say, particular to the topic of bias, certainly I do recommend that you use the information that this project has already generated. We collected primary qualitative data and implemented a large quantitative psychobehavioral segmentation across 3 regions. as I've mentioned. So, and in the guide, we provide a decision pathway to guide you on how to apply and build on our findings. And we also include simplified tools that you could use to assess if providers in the context that we worked are comparable to the context where you are or where you'll be implementing this work. So I would say please use that information is there, make good use of it. Thank you.
Thanks, Lydia, for sharing some of the complexities related to segmentation. I know you could talk about this all day. It's certainly an approach to be thoughtfully considered, and we do suggest you go to the Beyond Bias website and check out that that brief. It's really interesting, about 4 different projects where we use segmentation. Lots of learnings there. Next slide, please. In addition to implementation and learning, we're going to shift a little bit, because Beyond Bias has also focused on the ability to scale up the model. I know you're all thinking about that. And Brahm, you talked earlier about the 3 components of the Beyond Bias intervention: Summit, Connect, and Rewards. And it seems that Rewards is the most difficult component to scale up across settings. So, of course, the how-to guide will give implementers guidance on all 3 components, but what specific insights or recommendations do you have about scaling up rewards?
Yeah, thanks, Marta. Yeah, the rewards piece can be tricky to implement. So when you look at both the one-day summit workshop and the monthly Connect sessions, a lot of this, and again, this is a crude simplification, comes down to careful and meaningful facilitation of these events. And again, the how-to guide does a good job highlighting important implementation considerations for both these 2 pillars, the Summit and the Connect. However, in order for rewards to work properly, you need to develop some sort of data feedback loop. In essence, a new M&E system to collect information about provider performance. You analyze the data, and then you got to share this back to both providers and facility managers. And that system needs to be accurate enough to assess what it means to provide high quality and unbiased family planning care, but also needs to be trusted by participants and end users. So on that accuracy front, again, earlier prototypes of the rewards utilize smiley faces. We try to use HMIS data to kind of streamline that, but it didn't give us enough specificity and accuracy to kind of assess quality of care. So automatically, we're thinking about primary data collections to kind of better capture that information. And then that second point of trust, there were some prototype approaches where we had put the tablets on facilities so that clients could self complete the surveys on their own, but we ran into issues of like a lot of the clients understanding some of the questions, but we also ran into incidents of data falsification. So if a facility was providing youth services between 9 in the morning and 5 p.m., we saw a lot of data being entered late at night. So that being able to control the kind of accuracy and the trust is an important component of designing that reward system. So we know that the approach that we used here to calculate the reward score involved youth enumerators with tablets collecting data throughout the life of the projects across all facilities. That's very expensive, and we're aware that that's not going to be scalable. But again, our project was trying to use the data both for monitoring and evaluation purposes, but also as a proof of concept that rewards pillar as an approach could work. So a few insights and recommendations to consider as other projects, other countries are trying to implement rewards as part of their Beyond Bias approach. So I think one important thing to note is that you don't need a complicated tool with a lot of questions to assess provider and facility performance. So again, our client exit interview had about 80, 90 questions. About half of that was associated with quality of care. So, the team here at Pathfinder, we utilize psychometric analysis using a lot of fancy sets to kind of figure out what are the the dozen or so questions that can better get to assess provider performance as it relates to high quality care. So, and this is nicely identified in the how-to guide, but there's 14 questions that can help us assess the performance of provider that nicely align to the 6 principles of provider bias. And these are questions like, did the provider ask you if you had any questions? Did you feel that the provider judged you or you were scolded by the provider? So with that, you don't actually need to ask a lot of questions. Focus on the dozen or so that we've identified that seems to be able to detect provider bias, assess quality of care in an accurate manner. And once you know that you don't need a lot of questions to calculate the reward score, I think it's also important to think about taking advantage of data collection systems that already exist in your context. So for example, in some settings, the use of mystery clients is already used as part of quality assurance programs. So it's possible to integrate those 14 or so questions into existing mystery client tools to better assess quality of care related to provider bias. Alternatively, there are also some settings who have mentorship or supervision programs, which can integrate these new questions. And you can also potentially train community health workers to ask these questions as part of routine monitoring. So anywho, the how-to guide, I think, kind of identifies some of these potential approaches to consider as you think about how to best scale up rewards. So hopefully that's helpful, Marta.
It's very helpful, Bram. Thank you so much for the detail there. And I think everyone will find all that guidance quite clear in the how-to guide. So thanks for that. As noted in the chat, we're going to extend the panel a few minutes. We have a few more questions, so please stay on. We'll be wrapping up in the next 15 minutes or so. But as we think about scale up, we acknowledge that bias is a complicated issue and there is still much work to be done. And since we are here to discuss the how-to guide, adaptation, and implementation in different contexts, I'd love for us to think about future opportunities, which of course we know require donor commitment and support. So I'd like to direct the next few questions to Gwen from the Bill and Melinda Gates Foundation. Can you talk a little bit about how other donors can support the implementation and scale up of the Beyond Bias model? And also a little bit about what efforts are necessary to promote integration of Beyond Bias lessons into youth programs. Over to you, Gwen.
Thanks, Marta. So the first is actually going back to a point you made at the beginning of the webinar, which is to say there's actually a large variety, I think, of programs or projects in which the Beyond Bias model can be integrated. And so, obviously within youth-focused projects that are looking at improving access and quality of either contraceptive or other SRH services for young people. But I think there's a lot of opportunity to also integrate the model within large-scale family planning SRH projects that might be targeting all women of reproductive age, but we know that there's still intentionality that's needed for young people, or even within broader PHC or health system strengthening programs. I think, for donors, there's different kinds of donors, right? So we know that there's some donors, bilateral donors in particular, that often issue RFPs as part of their grant making. And so I think it's also important for the issue of bias to be incorporated within those RFPs as a key barrier and calling for solutions to address that. And then on the donor side, really looking at what's being proposed. Are people proposing something that goes beyond the traditional kind of status quo approaches, like training that we already know are ineffective? And are they incorporating things like the Beyond Bias model or some adaptation of that? I also think there's some opportunity to look at projects that might be focused on pre-service training of providers. And I know that the how-to guide gets into this a bit as well, but I think maybe not the entire model, but some aspects of the model like Summit and Connect could be integrated within pre-service training. And so that's another thing that should be looked at. In terms of one other thing I wanted to touch on that Bram did an excellent job on discussing was on the rewards pillar. And so I do think, depending if, what donor priorities are, if there's a donor out there that's willing to support implementation research, that another contribution to the field could be supporting implementation research around how to make the rewards pillar, increasing the scalability of the rewards pillar, perhaps by further testing out some of the adaptations that Bram discussed. The second part of your question was around integration of lessons learned. And so a couple of things to highlight, I think all of which have already been mentioned in the webinar, but just to bring it back for donors. I think one is really the importance of that there are many drivers of bias, and those drivers are going to vary based on context, and how even bias manifests itself will depend based on context. So it's really important, as Lydia was talking about, whether it's segmentation or some other type of qualitative work, that donors are supporting that, so that they're really understanding how bias plays out within the context in which they're funding a program, and then how best to adapt solutions. Another point to just emphasize is making sure that both public and/or private sector, depending on who they're working with, is engaged from the beginning to facilitate adaptation and integration of the solution within existing systems. And then two other quick points to mention. One is just around the data, which Bram did a great job of calling out, but just making sure that as donors that are looking to replicate this, that they're making sure that there's access to high quality data to be able to ensure that the rewards pillar is functioning, and also just to monitor the implementation. And then the last point to just conclude on was, I just think the learning that we had around taking a growth mindset cannot be overemphasized. So, the whole thing with rewards was not just recognizing those providers that were offering the best, most, unbiased quality of care, but also recognizing those providers that had made the most improvement in terms of their own attitudes and how they were treating youth clients. And I think that that's just a really important thing to make sure as donors that we're reinforcing that principle. Over to you.
Thank you, Gwen. I think everybody always wants to get into the mind of the donor. So we always appreciate your willingness to share, what might be on the future, what thoughts are out there for other donors. And as has been mentioned, this was a proof of concept, and we need donors to engage and invest in this work moving forward. So thanks for sharing your thoughts. We can move to the next slide. Obviously, the first question Gwen had, she was talking a bit about integrating beyond bias learnings into youth programming, but we've received multiple questions about applying it to other areas, which Gwen touched on. But Lydia, maybe you could expand on that a bit and talk about how you see the beyond bias model as transferable or applicable to other areas of the healthcare system or within the development sector.
Yeah, absolutely. And that's an excellent question. So the beyond bias model can certainly be adopted to address other forms of biases outside of the family planning sphere. For example, the model could be used to address service provider biases in MCH, for instance, maternal and child health, or to improve quality of care in other stigmatized health conditions, such as service to HIV and AIDS patients, or even to improve the quality of care for marginalized communities such as LGBTQ. So in a nutshell, the model is grounded in behavior change mechanisms that are applicable and adaptable to different biases beyond the family planning sphere, I think, and that's the beauty of it. So it's important that people understand it, that the core components of a model allows for that adaptability. Another point I think that Gwen has touched on, and I think it's also important to note, is just from this project, I think we've learned a lot about the shortcomings of training, especially for behavior change as we've done it. So I think borrowed from this experience, what we can take away from it is that any form of, when we're programming or when we have programs to be effective in behavior change, we need to go beyond the conventional knowledge sharing and embrace the full human element of those we intend to change. Empathy goes a long way. I can't say that enough. So we need to be slow to judge and seek to understand. Thank you.
Thank you, Lydia. I love those sound bites you have. And I think that, you know, part of where all these learnings came from was because we did not take a traditional approach with this project. You know, we really took as a multidisciplinary, you know, approach to the project. As we've discussed, you know, Beyond Bias took this very innovative interdisciplinary approach to addressing bias through a diverse consortium of partners who all had unique contributions. And, you know, that included, but as you mentioned, you know, not only looking at the sort of human condition and thinking through HCD and segmentation analysis, but also behavioral economics and the like. And these are very complex and diverse areas. So I'd love to move to the next slide, please, and have, you know, think about all of the coordination that goes into a multidisciplinary project such as this, and how we're constantly learning and adapting. I think you've heard that throughout this webinar. And maybe Gwen, you could expand a bit from a donor's perspective again on what has been learned about funding and supporting a complex multidisciplinary project such as this one. And what would you say to other donors? Because we've already noted we need donors to support this type of work. So what would you say to other donors to advise on how and why to fund such innovative programs such as this?
Yeah, no, this is an excellent question. And just to say, when we made this investment, we made a couple of investments around the same time, most of them related to young people that were multidisciplinary in nature. And it was a little bit of a learning, you know, journey for us as well, because we hadn't done that as much in the past. And we certainly have learned a tremendous amount from Beyond Bias and have documented that internally, actually, to help inform other types of multidisciplinary investments that the foundation might make in the future. So the first is just to say that as a donor, I actually feel like Beyond Bias really benefited from a multidisciplinary approach because bias is so complex, as we all know. So being able to bring in, you know, multiple perspectives and disciplines together, you know, in real thought partnership to deepen our understanding of bias, but also to really grapple with what could be the solutions. And I do think we ended up with a stronger solution set than if we had just relied on one discipline. That being said, a couple of things to kind of note for donors. I think one of the first ones, and this was something that we looked at even in the early stages, like during the proposal, is management of complex partnerships is really important. So even in, you know, when you, as a donor, you're having a grantee put forward how they're going to approach this, I would say don't just look at the programmatic piece, but really look at some of the management pieces. You know, is there real clarity on how roles and responsibilities are going to be established? How's the consortium going to be governed, including, and I would say in some ways, this is probably one of the most important things, how are decisions going to be made when there's differences of opinion, when you've got maybe behavioral economic, you know, experts saying we should approach it this way, and maybe you've got the HCD experts saying we should approach it the other way. You know, which one do you hold, you know, kind of as the way forward? And so being able to spell all that out in advance, I think really helps ensure that the multidisciplinary partnership moves forward successfully. And then two other points to mention. One is you've got to be able to take some degree of risk. So I think, you know, donors just being upfront with themselves, is that something they can afford? Some donors, like the foundation, can afford to take more risk than others. And then just making sure that they've built in flexibility in terms of funding and timing. And I really can't emphasize this enough. With human-centered design in particular, the interventions are not known ahead of time. So while a grantee can make a best guess as to what that might cost, it's pretty hard for them to construct an accurate budget at the time of a proposal, and donors need to understand that and have an ability that that can be adjusted over time once the interventions have surfaced. And that also can lead to shifts in timeline. I mean, Beyond Bias, you know, some of it was COVID related, quite frankly, but even just through the multidisciplinary approach, we did have to make a couple of, you know, extensions in timeline and also supplements to address some of the budget issues. Thanks.
Thanks, Gwen. I'm thrilled to see that donors have also learned from this project, and that, you know, the flexibility, the importance of flexibility and timing and risk. I'm sure it's scary for donors, but as this project and others have shown, the payoff is worth the risk. We've learned so much. So if we could move to the next slide, please. And I'll keep this one to you, Gwen, as well. And we're on to our final two questions. So thanks to everyone for hanging in there with us. But as a donor who has been involved from conceptualization and inception phases through the implementation and the now wrap up of Beyond Bias, the blanket question we want to hear is, what surprised you the most about this project to date?
Yeah, thanks. I'm actually going to highlight 2 points because they're interconnected. So the first was, I had the privilege of going out with Lydia and being with the team in Burkina Faso and, you know, witnessing Summit, being there. And for people that are on the webinar that know me, I've worked in this space for a very long time. And so prior to being a donor, I was on the implementation side and spent a lot of time, you know, training providers, working with providers. So truly, I wouldn't say skeptical, but I went in thinking, okay, this, you know, they're going to hear videos and stories like the video that we just saw. You know, how open and honest are providers really going to be in a group setting? You know, even if they're personally reflecting on this. And I was completely stunned. I mean, we had providers crying in the summit and standing up, you know, not being asked, just, you know, themselves standing up and sharing their own personal stories of, you know, when they had turned away a client or when they had treated a client in a particular way, and just how heartfelt it was in terms of them really thinking about this and thinking about how they could change going forward. So that was pretty amazing. And then at the same time, I was so surprised at how hard it was to capture and measure bias. You know, I'm in a room hearing from providers with Ministry of Health staff in that room, right? These are kind of, they're supervisors, and they're still being willing to share that, yes, this does happen. And we really struggled with what are the right questions and what are the right approaches to really be able to capture and measure bias. So I think it's those two things that most surprised me.
Thanks, Gwen. And your response about Summit reminds me of why we all do this work. I think with COVID, we've all been so removed from the field that even seeing a video or hearing your story is reminding us how important it is that we continue to move forward. So thanks for sharing that. As we wrap up our panel, I have one final question for Lydia. If we could please go to the next slide. Gwen alluded to it, and of course, nobody is a stranger to how COVID has interrupted our lives over the past few years. But aside from the COVID disruption, what were the biggest surprises for you as a project director during implementation that other implementers should consider if interested in adopting and implementing Beyond Bias?
Right, I'll have to agree with Gwen. And by the way, before even I answer this question, I just want to say, Gwen, your comments about a multidisciplinary project and the management of it, I feel it in the bone marrow. Like, I totally agree with you. I appreciate those reflections so much. But in the question about surprises, my greatest surprise will have to be the same as Gwen in terms of the challenges of measuring bias, the intricacies of it, and how do you disentangle system issues from provider own issues, and then the challenges or the uniqueness of the client who's a young person, and at what point do it's bias versus it's so many other prevailing issues. So it's hard to say anything positive about COVID, honestly, but the 6 months pause period was a blessing for us. And it's crazy because we spent those 6 months trying to go back to the drawing board and try to revamp a tool for us to be able to detect bias, because the tool that we came with from the design phase failed flat on the face. And yes, we've made some improvements. We've had some learnings, as Bram noted, but I cannot reemphasize how much this area needs help. We need more work in this area. So please pay attention to that. Another element I think for me is, it's not much of a surprise, but rather a point of reflection, is the level of empathy I now feel towards providers. Of course, this project was about addressing biases and how that act as a barrier for youth access to contraception, which is still valid, and I'm sold to that mission. But really, after years of talking and engaging with providers, I feel like I have more consideration and respect for them. And I generally think as a field, we need to think more about and be more careful about how we communicate with them and how we assess their work. Otherwise, we risk driving them to apathy. We really do risk driving them to apathy. So one, we are fragmented in a way that we implement. We are fragmented field. So we do feed them with conflicting information. That is one. And number two, sometimes the way we assess their work ignores the context within which they operate. And it can be frustrating for any human being. And a good point to make here is, for instance, decisions around a method of choice. And especially when it comes or relates to young people who we've had over and over again that tend to be more reluctant in choosing a method, even when given or cancelled on our methods. And so, you know, when assessing a provider, when they're trying to guide a young person, if we tell her you did recommend a method in the end and you're biased, I mean, ask yourself a question: what are they supposed to do? Picky, picky, ponky. I mean, what are they supposed to do? And so I think this is something we need as a field to revisit the definition of how we define informed choice, for instance, in the context of young people. I'll stop there.
Yeah, such an important point, Lydia. I couldn't say it better. So thank you for that. And thank you to all of our panelists for such thoughtful and comprehensive responses. You know, we still have lots to learn. We have to consider what we can do to measure bias. It brings with it many complications, and we have more work to do. How can we be more empathetic toward these providers while also addressing the biases they may have? So, you know, there is still plenty of work to be done, but the learnings from this project and the past few years are phenomenal, and we are so proud to share them all with you. So thank you for staying with us. And Lydia, I'd love to turn it over to you for a few final remarks.
Sure. Yeah, thank you, Marta. Thank you to my co-panelists and to you guys for hanging on for such an engaging conversation. So I hope we've inspired you enough, or at least stirred your curiosity to go check out this guide. But I would like to take this moment, or this opportunity, to really thank and appreciate the Beyond Bias Consortium, starting with our partners, including YLabs, Kimber Collective, and RAND. This was definitely a collective effort. Thank you for your partnership in this endeavor, and I hope that you too take pride in the accomplishment, or in what we've accomplished together. And to the dedicated implementation team at Pathfinder, shukran. Thank you. I also want to thank the Gates Foundation for funding this work, for being flexible with us. And to you, special thanks to you, Gwen, for your support and thought partnership throughout the years. Much appreciated. Please allow me to take a brief moment to honor one of our fallen colleagues, Bamweba Kuno, who passed away unexpectedly early last month. Mr. Bibi, as we fondly referred to him, was a chief crusader for youth and adolescent sexual and reproductive health and rights in Burkina Faso. He served as the Beyond Bias country manager since the inception of the project to the very end. So it's a little hard that we're wrapping up with him gone, but we miss him terribly. But we take comfort in knowing that his legacy will live on through this work and his other contributions in the country, the region, and beyond. Finally, next slide. As we've done previously, we will share the recording of this webinar along with relevant materials in the coming weeks. So please be on the lookout for that. And please also remember we have a repertoire of resources in our project website that you can access at any time and make use of. So please do use that material, do use that information. It was a research project. It was a proof of concept. So we've produced a lot of information that you can use. And then if you have any further questions, because this project is wrapping up, is closing very, very soon, please do email us at beyondbias@pathfinder.org. And as a parting shot, I would like to say this. It's been an incredible journey directing this project. And what a wild ride it's been, truly. We had our ups and downs, sweat and tears, for real. But most importantly, we learned a great deal. We learned a great deal. And you know, no matter how grim things got at times, because they did, or how much our views differed and how much our perspectives differed, our saving grace is that we kept our focus to the girl in the village. That's what guided us. The girl in the village. What does all this mean for her? How can her life be better because this project existed? Because that's all this is all about. That's all it's about. So I hope you do pick up the guide, and I hope you ask yourself the same questions. Above all, I hope that she remains your guiding star as you navigate through your work as well. Thank you. Thank you for your time. Thank you for joining, and have a good rest of your day or evening.